Hello, and welcome to my presentation about the issue related to the underutilization of palliative care by Sydney Macomber for Fort Hays State University. The community I will be using to implement change at is the Cancer Center of Kansas, and it's an outpatient facility. This is a national issue that I truly believe should be initiated everywhere, but for the purpose of this project has been downsized. The Cancer Center of Kansas was founded in 1975 by one physician with one office in Wichita, Kansas, and they were one of the only oncology practices in the state. Fast forward to 2019, they have 20 offices spread across the state of Kansas, providing state-of-the-art cancer care by board-certified physicians and OCN chemotherapy, biotherapy trained nurses. This company really bases their care off evidence-based practice from the very beginning, and in 1983 CCK developed the first community-based, nationally recognized research program that was known as the Wichita Community Clinical Oncology Program through the National Cancer Institute. It is now known as the National Cancer Institute Community Oncology Research Program, or NCORP. Since they practice in rural and urban areas, our patient structure consists of all types and backgrounds from those areas with a diagnosis of cancer and other hematological disorders. They also only see patients over the age of 18. The Cancer Center of Kansas is well known in the Wichita area, which is where its main office is at, but also is known for its many locations where their physicians travel. Some of their awards and recognitions include that in 2016, they were admirable statewide partner for their outstanding dedication and continued support for the American Cancer Society and Relay for Life in Kansas. Also, the research program, the Wichita CCOP, was recognized as the high accruing CCOP, or Clinical Oncology Program member, in the nation for cancer trial networks by the National Cancer Institute and the Southwest Oncology Group. In their main office of Wichita, they've been recognized multiple times in articles and by their patients for having the best doctors and nurses, and their chief nursing officer was honored with a Nursing Hero Award. The CCK mission is to provide personalized, quality, and innovative cancer care to patients throughout the state of Kansas in a compassionate and respectful environment, and to make available to most appropriate and current diagnostic and therapeutic modalities through our commitment to excellence in medical, oncology, and hematology. Working for this company personally, I know that in each of their different types of communities, they strive to really follow through with their mission and values. And if you visit their satellite offices and their main offices, you can really see the care and the relationships that the nurses and the physicians really build with their patients. So many of their offices, their smaller satellite offices, will consist of 2 to 3 nurses, a scheduler, and sometimes a secretary or an assistant, and they are there 5 days a week with the patients, administering the chemotherapy, reporting back to the physicians, and really monitoring the patient's symptoms. And then the physicians, they visit for doctor's visits one time weekly to sometimes one time monthly, and then if they need to be seen sooner for reasons, they can be scheduled at a closer satellite office or at the main office in Wichita. So what this means is that the daily staff gets to provide the best patient-centered care, build rapport, and really get to know their patients. CCK is also very community-based, and so they sponsor many youth ball teams such as soccer or summer baseball in several of their satellite cities. They participate in local Relay for Life, and their Wichita office puts together several teams of people for that event. They also participate in 5Ks as a Cancer Center of Kansas team for local nonprofits and different fundraising events. The company also sponsors state and national projects like the Wounded Warrior Project, the Kansas State Food Bank, American Cancer Society, the YMCA, and St. Jude's Children's Hospital. The company does a really good job, I think, of really living through their values by providing compassionate care, and then with their research trials and their research program that they have set up, they're always offering patients the most up-to-date and end cancer treatment that they can. The Cancer Center of Kansas really has a spirit of inquiry and evidence-based practice. So they make sure most of their nurses are certified by the OCN in chemotherapy and biotherapy administration. So that way the patients know and feel comfortable that their nurses are up to date on the administration of these medications, their uses, their side effects, and can provide proper education to patients and families. They also have their comprehensive research program that offers chances for patients to participate in clinical trials. The research program, the Wichita NCI Community Oncology Program, has affiliates with the Southwest Oncology Group, Alliance for Clinical Trials in Oncology, sponsored by Mayo Clinic and Memorial Sloan Kettering, MD Anderson Cancer Center, and the University of Rochester Cancer Center in New York. They also have a partnership with pharmaceutical, biopharmaceutical, and diagnostic companies, which in an effort to provide cutting-edge therapeutic options, even years prior to being FDA approved. So the Cancer Center participates in all of these research trials and research programs, and several recent approvals of agents used in oncology that have been granted by the FDA were made possible by efforts of the CCK research team and the patients that participated in this trial. So I know the Cancer Center really sounds like they cover all their bases, but unfortunately, like many hospitals, outpatient cancer centers, and outpatient clinics, they underutilize palliative care. And so many wonder why this is an issue, since we have home health and hospice, and many associate palliative care with hospice. And that's really one of the biggest issues is palliative care, adding that symptom management and that extra support team has been proven by Hugh and Associates to decrease patient symptoms, increase patient satisfaction, decrease hospitalization and ER visits, improve end-of-life care, which leads to the better quality of life for patients and caregivers, and in return also leads to the decreased cost and use of resources. There has been a couple randomized control trials that have studied the best use for palliative care, and as it stands right now, many use palliative care as a transition from home health to hospice, and study is showing that actually the sooner we refer our patients to palliative care, especially in the oncology setting, the better outcomes they have, and the more likely they will stick to treatment, and the more likely they will make their end-of-life wishes known prior to their last week of life. So not utilizing palliative care to its full potential is an issue, because essentially we are preventing our patients from receiving the best care they could receive, and so we are decreasing their quality of life and decreasing the quality of care. Now, what is helping us in this situation is that patients are also unaware that palliative care is an option. So what causes the issue of not having palliative care? So a research done by Hawley showed that nearly 1/3 of hospitals with more than 50 beds do not have any palliative care services. So palliative care specialty is a relatively new specialty, so it is still kind of unknown. There is a lack of resources to refer to, and there's not knowing that the resources exist. So there's not enough palliative care physicians and palliative care nurses, and that's just because it is so new, and because I think people are not educated about what palliative care is, and so that leads to the reluctance from physicians to refer and the reluctance of family and patients to be referred to palliative care because they have a misconception of what it is. They think it's hospice and they think they're not ready for that. And so we also have a big thing is funding and who's going to pay for palliative care, and restrictive specialist palliative care service programs eligibility criteria. It is strict, and many insurances clump it with hospice, and so we can't utilize palliative care specialists to their full potential. And one of the biggest reasons is funding, and we'll discuss that later on in the presentation. So, in a study done by Zimmerman and its associates, it was strictly on the perception of palliative care, and it was pretty much all negative things. Patients referred it as death and hopelessness, end of life, good death and good dying. It was linked with anxiety and depression. And when speaking with physicians, they had a fear of upsetting patients. They did not want to abandon them, which is a misconception, because palliative care teams work directly with primary care physicians or with other specialists such as oncologists, hematologists. Many patients saw the referral as an admission of failure, as an end of life, that they were giving up. And one of the biggest ones is physicians and patients' families not understanding the benefits of the referral. And so many people, healthcare professionals, patients, and clients still do not understand that palliative care can be provided concurrently with disease-directed therapy. It's just a matter of how we bill things and how we serve insurance and how we see them. And although there has been some progress within the oncology field, palliative care could also be used for other lifelong illnesses such as COPD, congestive heart failure, or chronic renal disease. And so it's so new, and there's just still a lot of studies going on about what palliative care is and how we can utilize it. So the social impact of palliative care, I spoke with a couple leaders, one locally here in Fort Scott. Kylie Gates is the nurse clinical supervisor of Mercy Home Health and Hospice. She works directly under the director, and she says they offer palliative care. On average, they have about 100 patients on service, 90 are home health, 9 are hospice, and usually 1 palliative care patient in their 60-day CERT period. She said that they use palliative care as a transition from home health to hospice, and that one of their biggest problems or barriers to using palliative care was that a majority of patients in that clientele have Medicare, and they do not use the word palliative care, and so restrictions are hard. Due to their restriction, it's hard to get people qualified for palliative care and symptom management at the beginning of service. She said because they don't meet sometimes criteria for like a skilled nursing for like home health visits, but they don't want to admit to hospice to get the palliative care. So it's an issue with insurance, and then also with the patients not wanting to really accept that title because it's linked to hospice. I also spoke with Paula. She's the Chief Nursing Officer for the Cancer Center of Kansas, so she's in charge of the main office and its satellites. She said one of their biggest issues is the misconception from both medical staff and patients. And she really thought, as a company, when palliative care became big, they would utilize it more to take stress away from the physicians and allow them to see a specialist for pain management and for symptom management. And she says they still do refer a lot of patients out, especially for pain management, but it's just hard to get them on an outpatient basis, referrals covered for those other palliative care things, such as dietitians or light physical therapy, or to a chaplain and to a social worker when they haven't been hospitalized due to insurance and funding reasons. Another issue she thought was nurses in their rural satellite offices report that patients would need to drive a minimum of an hour to see a palliative care specialist. So there was an oncology clinic in Fort Scott where Mercy Home Health is, but they didn't really they didn't have a palliative care specialist. It was part of their hospice team. And so the closest one for us would be an hour north, and then the same for our other satellites. The closest for them would be, Wichita, Kansas area, or the Kansas City area. So they both were still looking into the idea of palliative care and said they're providing education, but that one of their biggest barriers is insurance and trying to figure out how to bill for all of their services. So, like I said, services available for palliative care vary per area, but there are many options close to the CCK main office in Wichita, and then some of the satellite offices do have, that availability. So we have Mercy Home Health and Hospice, as mentioned before. Ascension Via Christi is a hospital that I know of in Pittsburgh and Wichita, Kansas, and I know they have other facilities that they offer a comprehensive palliative care program. And then getpalliativecare.org. Patients can search a directory of of providers and locations where they specialize in palliative care, so they can see options that provide care in the setting that they desire. So if they're wanting it to go to a hospital that has palliative care, or if they want it in-home, in a nursing home, or if they want to see a palliative care specialist in the clinic or in the office, this directory is loaded with education about palliative care, where to find them at, news articles about why to utilize palliative care, and it's just a really good resource for the community and for those clinics or satellites to use to find one close to them if patients do request a referral to a palliative care specialist. So, research being done about this issue is the American Cancer Society is one of the biggest funders, and they are currently funding more than $26 million for cancer survivorship and quality of life research. And they call this their palliative care research because it includes relieving cancer pain, managing side effects of cancer treatment, improving the lives of children and young adults with cancer, and the studies of cancer survivors. And so this is important because when a big company or a big well-known research platform starts to research palliative care and its advantages, that's how changes are really made for funding and in how care should be administered for that when it's proven to be effective. So one of the biggest things with palliative care is eligibility and its cost. So palliative care is for people of any age, from pediatrics all the way to geriatrics, and at any stage of illness, whether that illness is curable or not, and it's chronic or life-threatening. So again, some examples are cancer, chronic kidney disease, CHF, chronic obstructive pulmonary disease. Any of those things or illnesses that are chronic and could cause complications that really could benefit from closer monitoring, symptom management, nurse visits, closer physician visits, that would help keep those patients from pain, from nausea, from difficulties from dialysis, from fluid overload, any of those symptoms you can think of that someone can go in and monitor, and then maybe we catch those things on early that we can treat on an outpatient basis instead of having to be admitted. So eligibility for insurance purposes vary based on your type of insurance. Almost all palliative care resources are available when a patient has been hospitalized or in hospice care. And then usually still then it's just on a short-term basis for whatever the certification period is. The Medicare website, which covers a lot of these chronic illness insurances, that's what kind of insurance they have is Medicare, groups palliative care and hospice in the same category, and they use palliative care only as its mean of comfort and not curative. And so in this instant, Medicare pays 100% of these services. So when I spoke to Kylie, she said a lot of their palliative care patients are ones that had home health, they're transitioning to hospice, and they'll be on the palliative care service for their 60-day cert period until they get comfortable with the ideal of hospice, they realize what palliative care can offer them, and then they make the transition to the hospice team for the closer monitoring, the 24/7 access, and the extra resources. But in all reality, if palliative care was utilized correctly, it could be seen and used as a preventative measure. And if we could get insurance payers and hospitals to see it as a preventative measure, eligibility would be able to start at the beginning of service. So when it comes to funding, there is very modest reimbursement for palliative care specialists. So when the physicians evaluate and assess the patients, and other members of the palliative team, the nurses, the social workers, and the chaplains, cannot bill for their service. So at this time, the revenue generated by these teams falls short of actual cost. And although hospitals and healthcare systems agree with the goals of palliative care, they want to see evidence of value and return on their investments in adding these palliative care specialists. And unfortunately, there have been cost analysis done of palliative care services that demonstrate cost savings, but these studies are limited due to small sizes, health system perspective, and design. There are very few of the studies are randomized control trials and have included the cost to patients, caregivers, and societies. And so really for the purpose of palliative care has been studied to show all the good things, the increased quality of life, the decreased pain, and the decreased symptoms, but it hasn't been studied enough to really prove how cost effective it can be in the long run as a preventative measure that should be started at the beginning of treatment and should really be utilized more by our long-term patients. Because we're using palliative care at end of life or at time of diagnosis, it is considered tertiary care because it is aimed at reducing symptoms and disability for those who have already been diagnosed and are being treated for a disease. So it aims to reduce, palliative care aims to reduce damage, focusing on the whole person, mental, physical, and social rehabilitation. And so if we could get palliative care used earlier on in preventative measures and monitoring people, it could become primary and secondary care as well. So the Cancer Center of Kansas, the community that we're talking about to really get palliative care in there, has strengths and weaknesses. So its strengths are that the nurses and physicians truly want to provide the best care to their patients. The company as a whole wants to provide care based on evidence-based practice, and they are already known for participating in research trials and have quality results, which means they have a good name. So they play into their weaknesses, which are a lack of education regarding the importance of palliative care, lack of funding to provide resources at time of diagnosis, and the reluctance of some staff to accept the difference between hospice and palliative care. So I truly believe once we educate our healthcare workers, our nurses, our physicians, our social workers about the importance of palliative care, that we kind of get rid of weakness number 3. Once they know everything about it and know its benefits for our patients, we lose that reluctance and number 1 takes over, where they want to provide the best care and they want to provide evidence-based practice care. So, in addressing these strengths and weaknesses, like I said, once they have the proper resources to understand palliative care, They want to pass this knowledge on to their patients. So what Cancer Center of Kansas should do, they already have a huge research team. On that research team, they create a subset palliative care team. And this is people who maybe know a little bit about it, are more interested and wish to learn about palliative care, are excited about the transition. And then we send them to seminars and training services. We enroll them in online classes and webinars just to really build their knowledge base, get them to really know the benefits and to what benefits it provides to the patient and the cost it could save the Cancer Center of Kansas as well as our patients and our contracting hospitals. This team should include physicians, nurses, and social workers. And then once they have a solid ground about the topic, have them train the remaining staff. Start with small things like emails about the education, hanging posters on bulletin boards about what they've learned in break rooms and in hallways, and then see if your education and compliance team has a palliative care module that could be assigned to appropriate staff. So what we want to do is, Cancer Center of Kansas is such a big entity that once they, I think, realize what palliative care can do for them, they could be groundbreaking. They could start a research team that, they add a palliative care specialist and a palliative care nurse, and we refer our patients from our oncologists to work seamlessly with our palliative care specialist, and then they public research about their findings, about the things that are consistent with the studies that are out there, and we focus on the cost of savings that palliative care does for these entities. And then, big thing is how we're going to fund this. So CCK already has a big research team that knows how to file for grants and to fund research. And so this would be, the same thing. To fund this, there's organizations that fund cancer research, such as the American Cancer Society, the American Institute for Clinical Oncology, the American Society of Clinical Oncology, the National Cancer Institute, and the National Palliative Care Research Center. So they all have grants that facilities and entities can apply for, and if they meet the qualifications and have the right things in place, these entities help fund that. They help pay for the extra staff, they help pay for the research teams, to study the extra patients, and then since CCK has so many satellites in rural areas, ruralhealthinfo.org/funding for hospice and palliative care has a list of grant opportunities for institutes in rural areas to take advantage of and apply for and get the funding they need, to get palliative care in the smaller areas via an actual clinic or via telemedicine, where they have a provider that they set up, teleconferences with to have appointments with patients. So overall, my recommendations for implementing this change into, CCK's standard of care in their regimen of care would be first for some of their main physicians, their nurses that have been there a while, their chief nursing officer, attend in-services by board-certified palliative care specialists. Once they have a research team in place for palliative care, have team members join the American Academy of Hospice and Palliative Medicine, which then provides them to a whole slew of new education, resources, continuing education, yearly seminars, webinars, and just a big support group to advocate for our patients and to advocate for the need for our physicians to be specialized in palliative care, as well as our nurses and our social workers. The website listed there, nhpco.org, offers online courses and webcasts on demand, and it's a really big hospice and palliative care organization. They are striving to advocate for our patients and the need to implement palliative care into their, their standard of care. And so the facility then can apply for grants to help funding, to make a research team to study the benefits of palliative care, to advocate for palliative care referrals from our nurses once we educate them. You know, we advocate our patients to have home health and hospice referrals all the time. So once they know the education and know that the resource is there, you know, I think as nurses they will advocate for our patients to have that just like we would anything else. And then our physicians, as they start in our facility, as they start to, you know, want to add a palliative care specialty, the Center to Advance Palliative Care website is a great place and a great organization because they focus on providing the things they need and a stage and the resources to build that palliative care specialty and how to make it successful. And then the last page is just my resource page. And so I got it from the Cancer Center of Kansas, the Journal of Oncology Practice. There's an article related to the barriers to access to palliative care, and then as well as the impact of timing and setting of palliative care referrals, and then the perception of palliative care among patients and caregivers.